You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, President of Parker University, and this is Clinical Rounds, where we discuss topics of clinical significance. Today I have a very special guest, Dr. Blake Graham from our own Dallas clinics. Dr. Graham, thanks for being here.
Thanks for having me.
So tell us a little about yourself.
So I am a Parker grad, 2015 graduate, and I specialize in sports chiropractic. I went into private practice right outside of graduation, where I dove right into the world of sports chiropractic and strength and conditioning. My first clinic was inside of a gym, so I had firsthand experience working with very active people.
And you worked with Major League ball players too.
That's right. Yeah, so the gym that I was a part of actually did off-season training for a lot of Major League Baseball players. So part of that experience was having to learn very quickly on a lot of the demands and needs for these types of athletes.
So if you're doing sports chiropractic and taking care of baseball players, you have to be pretty good with the shoulder.
You have to, no question.
That's the thing. So what are some of the things that clinical tidbits you'd like to bring to our audience today?
The first thing, anytime I'm working with a unilateral athlete like a baseball player, so they are just using one limb all the time, is there's going to be a lot of mechanical adaptation that has to happen. Most of those players have been playing since a young age, so there's already some bony changes that have happened, so we have to keep in consideration that their anatomy is not the same as like maybe you or mine. So we have to keep that in consideration when measuring joint range of motion. At the same time, they also have a lot of compensatory movements that we need to be aware of, especially in things like the scapula and the thoracic spine.
So it's important to know there's a glenohumeral joint moving, and I guess the best example of how the whole chain works that I like to go to is what happened to the pitcher Dizzy Dean back in the 30s. He was playing the All-Star game. He broke his great toe, so he's throwing these pitches, but he like put the brakes on for his follow through because it was hurting his foot, and he ruined his shoulder, and he was never the same after that. That the complete kinesthetic chain needs to be evaluated. You can't just disassociate a AC joint from all the motion of the scapula. And we learn in school about the ratios of how much motion, the scapular motion, there should be compared to the glenohumeral, but there's so much more than that. So what are some things that you can share with us to make sure that we're addressing this, in addition to adjusting the spine, which we know, there's studies showing that adjustments to the thoracic spine helps reduce shoulder disorders or pain. So, but again, it makes sense. It's part of the whole range of motion of that shoulder is your thoracic spine. What else besides adjusting the thoracic spine would you do to address that scapular glenohumeral rhythm?
The first thing I like to do is just watch the scapula move. So I'm going to take a look at where it's just resting, seeing if we have a high or low shoulder. Oftentimes we just look at the shoulders and try to say, oh, that's a high shoulder, that's a low shoulder, but we don't know which one's actually adapting inappropriately. So making sure we're seeing if the top border of the scapula is in an appropriate place. After that, I'm going to take a look to see if it's moving through the plane appropriately as well. So as we try to reach overhead, where is the inferior border of the scapula tracking? Are we actually creating enough room for the glenohumeral joint to move? So if we're not getting enough movement through that scapula, everything else has to compensate. We're going to close off space within that joint.
And get impingement syndrome at that point.
Absolutely.
So without that motion, we want to make sure we're mobilizing it. And I've done myofascial work, I've done pin and stretch, Graston, scapular adjustments. What do you use? Stabilization more, or are you using myofascial work, adjustments? What should the clinician be using with this?
Really, the best approach is going to be a multifaceted approach. We have to kind of look at a range of different options depending on what they're presenting with. So myofascial release is fantastic. A lot of the scapular issues really do stem from muscles overworking, especially in throwing athletes or overhead athletes in general, subclavius. I think subclavius is overlooked as the clavicle attaches to the scapula. And so we can't really just only look at the scapula. We have to look at how the SC joint is moving as well. And if that subclavius is holding the clavicle down, that's another reason we may not be getting enough room in the glenohumeral joint.
And there's that the cranking of the clavicle that it's like the crank in the old cars to allow room for as you move for the brachial plexus underneath it. So how do you address the subclavius?
That I'm going to dig in there. A lot of myofascial release into there, and after we release it, then doing some motor control work to make sure that we are teaching the joint how to move through that space.
What do you do?
I'm a big fan of wall slides. So getting on the wall with a roller and trying to press up and actually teaching the serratus and the lower trap how to help guide that scapula through the plane of motion.
So there's 17 muscles that attach to the scapula. One of them too tight, one of them not fired at the right time, you have dysfunction. Like, do you address all 17 of those muscles?
Indirectly, yes. It's very hard, if not impossible, to isolate a muscle. So I try not to teach my patients that we're training this muscle and that muscle, we're training motions. And the body is going to help figure out how to get there.
Now, this is going to help chiropractors who went to school when I went to school, when we lived in the world of isolation and tubing exercises. You're trying to isolate the supraspinatus and the subscapularis. So that you're actually, that's passe. We're doing motion patterns now, not trying to isolate the individual muscles and reactivating them that way.
Correct, and that's one thing we've even learned with orthopedic testing is that if I'm going to do a Jobs test, as much as there is EMG activity in the supraspinatus, I am not isolating the supraspinatus through that test. It might be the most isolating, and in fact, I believe that is the most isolating test that we have. It's still not perfectly in isolation, so we can't forget about the other muscles that are going to work alongside with it.
And with it, by people who are trying to isolate this, most people my age, most men who have been athletic will have ruptures of their supraspinatus. If I took an MRI of it, we'd find all sorts of tears in there. I'm still doing virtually everything I want. Other things can compensate for the loss of a muscle. You develop patterns that compensate it. There's broke and there's fixed, and there's somewhere between that where most of us actually live. So somebody like me, let's say I'm going along and I've got some altered mechanics in there, but I'm not going to ever get back to where I was when I was in my 40s or 50s. So what would you do for somebody like me? How far would you want to take that person? And when you say that's as far as we can take it?
Depending on the goals of the patient too. So if I have somebody who wants to be very active, that's where I'm probably willing to give up a little bit more. You know, health is kind of the byproduct that it has to be thrown away when you want to be active, if you have compensations. So we have to kind of have a conversation about what are you willing to give up. So if you want your shoulder to move, great, you might have back pain, but that's okay, but that might be tolerable and that might be perfectly fine. Or we can do things that are palliative to keep you moving. So maybe it is going to be the elbow that has to kind of give in order for the shoulder to move like it should. Or maybe it's the scapula. Maybe it is going to be a little bit tighter, but our bodies are very resilient and it's going to figure out a way from get to point A to point B. We're just going to try to reduce the amount of stress that may be going to that joint.
So how does the hypomobility of the thoracic spine play into the motion of the shoulder?
It's going to make things a little bit more difficult to do overhead motions. Again, I think there are ways that we can find compensations, especially with training modalities. We want to make sure that we are addressing that hypomobility by seeing if we can increase a little bit of mobility into the thoracic spine, but then teaching the scapula to move maybe a little bit more. So if you have hypomobility, you may have to create a little bit of hypermobility, but there's ways you can stabilize that hypermobility. You know, I think that's kind of a term that can be overused. You know, we're talking millimeters of movement. We're not saying that we're going to tear a ligament out of place in order to make the
No, yeah. So getting thoracic spine motion in there, it's, you know, most people sit at a computer all day long. They lose that. They might be a little kyphotic. Their chest, their pecs might constrict a little bit, so they have this disorder. You're trying to open them up a little bit. You're trying to get more motion there. You're trying to make sure the muscles fire at the right time and enhance the body's ability, basic chiropractic principle of enhancing the body's ability to heal itself.
Yes.
Throwing athletes are unique. You know, some people, like you said, you're giving up your health to throw that ball because it is over time going to cause issues. How about a swimmer? What would you do for a swimmer that starts having bicipital tendonitis? They pop in there. What would you look at for that person?
With swimmers, we often see that the shoulders like to rise up because they're doing so much overhead, and that pulling motion with the lats and the lower trap is going to cause adaptation to try to cheat. So as the body is trying to get more efficient at what it's doing, it's going to creep in the direction that it's trying to create more space. So generally with swimmers, we're going to see that the shoulders want to rise up, and we want to make sure that we aren't creating instability in that inferior glenohumeral ligament. Oftentimes with the swimmers, we're going to see more of the posterior labral tears versus an overhead thrower. We're going to see the slap tears. So that posterior labrum, we're going to make sure that there isn't the true instability of the posterior glenohumeral ligament and that inferior glenohumeral ligament.
So for swimmers, I know that, see, as you're swimming, your arm has no resistance, it's in the air, and then it's all right here. And they did some studies, this is back when I was in school, they found that the Olympic athletes who were breaststrokers, who had an underwater recovery stroke, they actually worked the muscles that would help stabilize it, and they had less shoulder issues than the people who are straight freestylists. So that there's things you can do, maybe even, would you recommend exercising the muscles that are undertrained in a sport to compensate?
100%. It's extremely important to work with a strength and conditioning specialist who understands the demands of that sport and understands how to analyze a joint and the joint motion. So with any of those athletes, I want to make sure not only are we training the muscles that you need to use, but also the muscles for recovery, deceleration. Almost more important in the gym than in your training.
Because you're getting plenty of pecs and lats in your sport. That's where you see protraction. When people are relaxing, you see a swimmer sit there with their shoulders protracted so much, where actually you want to actually develop the muscles that will stabilize it, and maybe the retractors to help compensate for that. Is that true?
That is absolutely true.
So swimmers are good. Now, what else? What are the sports you find people tend to have shoulder problems with that you have the ability to help them with? Golf, tennis?
Golf, we are closing a lot of glenohumeral space with the golf swing. You're bringing your shoulders in, and especially if you already live here, you're just doing that more and more. Most people don't think that golf is a very demanding sport, but as we've seen in the pro golf tour, the amount of the young athletes that are coming through who are spending most of their time in the gym, they aren't necessarily on the golf course. They're inside the gym, and that's what's kind of pushing the game further and further.
And I watch these when they're doing this, they're doing a lot of exercises for anti-rotational type exercises.
Yes.
So how does that affect the shoulder?
The force that dissipates from the ground all the way up through the shoulder has to go through the spine. There's no way around it. If you're in a sport that has a lot of unilateral motion and a lot of rotation element, you don't necessarily want to keep rotating more. We know that the multifidi and the rotators have a very important job of rotating, but also keeping those joints in place. So we don't want to necessarily create so much mobility through the spine that we're over-rotating. It has a super important job of deceleration, once again. So those rotators, the only way to really train them on that deceleration is the anti-rotation movements. Extremely important for any unilateral athlete to work on anti-rotation. They do so much rotation within their sport. We don't need to keep moving that joint over and over.
So what I'm hearing to summarize what we've talked about is the joints that move too much, we want to stabilize. The ones that aren't moving enough, we want to instill motion, adjust, or provide motion. Is that accurate?
It's fairly accurate. We want to make sure that each joint within the kinematic sequence is going to be appropriately addressed. And so if we're not doing a full, like you said, a full body screening, if I'm not looking at the hip when I'm talking about the shoulder for a lot of these athletes, we might be missing the key to why all that force is going into the shoulder and creating pain or dysfunction. And
when I was in practice, I frequently, when I'm dealing with athletes, like for Navy football, look at the hallucis, make sure it's moving enough, because if that's hypomobile, you're going to not have to engage the windlass effect. You'll bleed power. It affects the chain all the way up. Well, thank you for spending time with us today. This has been a great conversation, and you've been listening to Dr. Blake Graham, and this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.